for that beautiful welcome and for putting us all in a good place for today. I'm the co-chair, along with Ro, of the Perkins Reconciliation Working Group, and I'd like to thank all of those people who are here today who are also part of the group: Donna, Page, Ruth I saw before, Richard, Alicia, Shannon. Thank you all. And thank you, Christian and Jonas, for letting us take over this week's seminar on this special week. So as a medical research institute, we're looking at the role we can play in reconciliation, and we're hoping to formalise that with a plan later this year. And it's a huge step for us as an organisation, but it is a crucial one, because how can we talk about our goal to improve the health of all Australians and all humans without first looking at our First Nations people who die on average 8.8 years earlier than non-First Nations peoples? And to put that into perspective, it's more than 3,000 days. It's 8.8 years is an outrageous statistic. But when you know the history of this country, unfortunately, it's not a shocking or surprising one, and it really should be. So the theme for National Reconciliation Week this week is now more than ever, and we want to step into the conversation in the best way that we think we can as a medical research institute, and that is through science. Because perhaps if we can convince or show people like you, our supporters, as well as the scientists and people in the industry, through undisputable research, that change is needed and that reconciliation is very much a matter of life and death, more people may listen. We are uniquely placed to play that role today, and we hope that you leave considering your role. So now I'd like to introduce Professor Andy Redfern. Andy Redfern is Associate Professor of Medical Oncology at the University of Western Australia, Associate Director of Clinical Strategy at the Harry Perkins Institute of Medical Research, and I believe standing CEO this week. He's also Consultant Medical Oncologist at Fiona Stanley Hospital and Medical Director of Linear Clinical Research, specialising in early phase human trials. Thank you, Andy.
Thank you very much. Well, thank you for the opportunity to speak today. And I'd like to start by, again, acknowledging the traditional custodians of the land, the Whadjuk people of the Noongar Nation. Pay my respects to their elders, past, present, and emerging, as well as to any Indigenous people here today. I also acknowledge the contribution of Indigenous people to both science and to medicine across Australia. So the topic today, the tale of three cancers, biological and therapeutic drivers, what's that about? We have been working, there are obviously many types of cancers, and I'll tell you in a minute why we've chosen three in particular. It's not that those are the only important ones, but you've got to start somewhere, and trying to do everything all at once, you tend to get nothing done. In terms of the biological and therapeutic drivers, that's talking about the way that the nature of the cancer, when you look at it in detail, may actually be partly responsible for the poor outcomes we see for Aboriginal Australians, and also how treatment may interact with that and how we may not be giving best treatment to people. Okay, so the problem, why cancer for a start off? This figure really kind of epitomizes the problem. These are death rates essentially from cancer for Indigenous and non-Indigenous Australians. You say from this point on in the talk, I will use the term Aboriginal to refer to Aboriginal and Torres Strait Islander people. And here we see the death rate per 100,000 people of the same age. We see that there's been a 16% drop in death rates in cancer for non-Indigenous people, but for Indigenous people, there's been a 26% increase. So things were worse, and they're getting worse. And this goes right up to 2015, so this is pretty recent. So we first asked, well, who is dying? And then we wanted to know why they're dying. Where should we be looking? This firstly shows the most common cancers in Aboriginal Australians. 2010 to 2014, that's the most recent national data that looks at the whole country. And we see the top few cancers, and that's where we want to focus our efforts, obviously. Lung cancer, the most common cancer in Indigenous people, and also in the general population. We've got breast cancer, colorectal cancer, prostate cancer, and head and neck cancer as the top five. So this is how many cancers there are. What about the disadvantage that we see in Aboriginal people? Where are they more likely to succumb to those cancers? And here we see the biggest gaps, and the red figures here, the green bars are the non-Indigenous population and the blue bars are the Aboriginal population. And the red figures are the gap, the number of extra people that die who get that type of cancer. We see that the biggest gap is in fact head and neck cancer. Almost a quarter of Aboriginal Australians die of head and neck cancer when they wouldn't die if they were in the non-Aboriginal population. We also see then colorectal cancer and breast cancer at 9% and liver cancer. And then we've got prostate cancer and lung cancer as slightly smaller figures. So what we really wanted to do is look at how we can save the most people. What are the actual, in terms of the number of people, extra people who die, where are the biggest problems? If we do the math, add in those two graphs together, this is what we get. We see head and neck cancer's got the biggest gap, 26 extra deaths per 100,000 people a year. Then we see breast cancer, colorectal cancer, and lung cancer. And the three cancers we've been looking at so far are, in fact, head and neck, breast, and lung, and we are coming around to colorectal cancer, hopefully next year. So those are the three cancers that we're talking about, our initial priorities. Now, I'm a breast cancer specialist. I treat breast cancer. I have something like 600 breast cancer patients that I look after, not all at once, but through the year. And so that's where we started. That's what I know most about. Doing what you know is most likely to be successful. The study methods, who do we study here? It's a little bit different for each of those three cancers. For breast cancer, we looked at all Aboriginal people in Western Australia diagnosed with breast cancer 2001 to 2016. So that, when we started, this was about 2017, is about everybody on record, essentially. The identity of people came from the WA State Cancer Registry that collects all cancer diagnoses. And we took for study every Aboriginal person and 3 times as many non-Aboriginal people. And they were matched to try and get the same age of patient and also the same degree of remoteness. So we looked at a pretty remote set of non-Aboriginal people also to remove remoteness as if from the equation to leave Aboriginality in. And that left us with over 1,000 people we've been looking at. Head and neck cancer, slightly different approach. We actually looked at the South Metro Aboriginal population who've had head and neck cancer. It was more quick for access to records, and that represents about half of the people. There's only really 2 big centres that look after head and neck cancer, and much more specialist and intensive treatment. So we looked with a South Metro database of people. Again, we matched 3 to 1 to non-Aboriginal cases, and here we had 80 Aboriginal people, 240 non-Aboriginal patients. Finally, lung cancer, we're just doing last year and this year. Again, we went back to the cancer registry for this, as it's a more spread out population, treated in lots of different places, everybody between 2010 and 2022, and 2 to 1 matching, as there were more patients here, 287 Aboriginal people, 574 non-Aboriginal patients. And we had a lot of ethics committee approvals. We've worked with the Aboriginal reference group from initially Breast Screen, and we also have Aboriginal representatives who have lived experience of cancer, as well as a number of people who work in the health services in various ways, also have Aboriginal heritage. So how did it go with those 3 cancers? Breast cancer we've been doing for probably 10 years in total. And the first thing we looked at, as we looked at this in the most detail, is there more breast cancer in the Aboriginal population compared to the non-Aboriginal population? And the answer to that one essentially is no. In fact, breast cancer is less common in Aboriginal people. And to put this slightly complicated looking graph together, about 1/3 less case in Aboriginal people. If we look at 100,000 people in a year, we see 59 Aboriginal people getting breast cancer and 86 non-Aboriginal. So quite a bit lower rate. That has been seen elsewhere. In Northern Territory, it used to be about 1/3 as many people. But they've also, in Northern Territory, looked over time, and they've seen there's an increasing rate in Aboriginal people, likely due to changes in lifestyle. And I think this is where, when we talk about reconciliation, that the causes of excess cancers and excess deaths are very much due to factors of colonisation. When we look at the drivers of different cancer rates for breast cancer, why is it Aboriginal people may have lower rates? We see things like childbearing. If you have more children and earlier children, you're less at risk. If you breastfeed for longer, you're less at risk. If you lose less contraceptives or hormone replacement therapy, there's lower risk. if you eat a good vegetable intake and lots of exercise, if there's not any great degree of obesity, and if alcohol consumption is low, then all of those things lower your risk. But many of those things have been brought in to the Aboriginal lifestyle by colonialisation and sort of Western influence. So those are the extrinsic factors. And what might be causing this lower rate? Well, we haven't been able to look at the extrinsic factors, but we're looking at those in the future. When you want to know about diet and exercise and things like oral contraceptive use and things of that nature, you've really got to ask people when they're there. And those things tend to be poorly recorded in the medical notes, which is where we've got most of our information from. So in the future, we're going to be looking at these different factors much easier when you see people as they are treated. However, what we do have information on is the ones at the bottom, and these are not lifestyle things, but these are intrinsic things about a person that really you can't alter, but you can be wary of risk. And that's looking at mammographic density and also genetic risks, things like the BRCA genes and other genes in families that increase your risk. So did we see any difference in Aboriginal people that explain their lower rate of breast cancer? Well, firstly, breast density. Now, just to give you a quick introduction to breast density, here we've got 3 mammograms. The one over on your left is low breast density, going through to high breast density on the right. And if you're a lady and you have low breast density compared to somebody else who has high breast density, you've got your risk of breast cancer at a fifth. Putting it another way, if you have high breast density, your breast cancer risk is 5 times as high. So was there any difference in the Aboriginal population? Did they have lower breast density to explain this? And we've done this work, and yes, indeed they did. We saw that, in fact, this graph over here, the light grey boxes are the spread of breast densities in non-Aboriginal people, and the black boxes are Aboriginal people. And you can see in that very low density, only 1 or 2% breast density, very black mammograms. You see that about 50% of Aboriginal people have low breast density compared to only around 20% of non-Aboriginal people. And this indeed would drive a lower breast cancer risk. The second thing, genetics. Lots of people know about genetic genes that put you at risk of breast cancer. And many people, when they come in, they want to know whether they may have had a relative who's had breast cancer, whether it's a family history, whether they should have genetic testing. This little pie chart is a list of the genes that we know can influence breast cancer risk. And the main 2 that everybody knows about that we tested the BRCA genes. Famously, Angelina Jolie has BRCA1 and had double mastectomy prophylactically, which she did publicize to try and raise awareness of this. So when we look at the BRCA genes, when we look at what's been published so far in Aboriginal Australians, there is no data. Nobody's ever looked. We have therefore looked, and we in fact saw that Aboriginal women were much less likely to have BRCA genes. The near boxes, the blue box is the Aboriginal women, and the orange box is the non-Aboriginal women. And we saw of the women that were tested, there was about 4 times less likely to have a BRCA gene in people that already were having tested because of family history. Putting it as a whole population, about 2.5% of the breast cancer population had a BRCA gene in the non-Aboriginal people, whereas it was less than 0.5% in the Aboriginal women. So that may again explain this lower rate of breast cancer. So a low rate of breast cancer is good, but what about survival? And there the story unfortunately found is very different. This is that population from 2001 to 2016. Every Aboriginal lady in WA who had identified as Aboriginal during diagnosis compared to the non-Aboriginal group. This is what we call a survival curve. And what we have here, we've got the 2 lines. The blue line is the non-Aboriginal women, and the red line, the Aboriginal women. Where those lines, if those lines drop right to the bottom, that means everybody has died. Whereas if the line is right along the top, then 100% of people are alive. As we can see, the blue line, it stays much higher than the red line, and that's the death rate. And when we look at 8 years, we see about 10 versus 40% death rate. So 30% gap for Aboriginal women in increased risk of dying. First question most people assume is that it'll be delayed diagnosis, lower screening, and that women are coming later who are Aboriginal, and it's due to stage, so the size of the cancer and how much does it spread. So what about stage? We wanted to get that question out of the way first, because lots of people looked at stage and had seen somewhat high stages. So when we look by ancestry in these 1,000 women, we do see moderately a higher stage in the Aboriginal women. This stage 1 here is very small cancer with no spread. A stage 2 cancer is a bit bigger, sometimes starting to go to lymph nodes. Stage 3 is a pretty big local cancer with lymph nodes involved that hasn't spread. Stage 4 is a cancer that's gone to elsewhere in the body. We see that about 20% more non-Aboriginal women had stage 1 disease, and that 20% of Aboriginal women without stage 1 disease, it's spread between stages 2, 3, and 4. So we wanted to set that aside to a certain extent. It has been looked at. So here we've got that 30% gap, that 30% extra people dying. That green segment is both the stage and socioeconomic differences. So that's poverty and education. So we've factored in those. What we find is we've got 18% of that 30% where we have no idea why there's an excess death. This has been looked at extensively around Australia, and everybody comes to this conclusion of somewhere between 10 and 20% extra death rate, and everybody's not found a reason why. So the field's been kind of stuck, really. How do we move forward with this? There's been a lot of looking at stage, there's been a lot of looking at the culture, the remoteness, the socioeconomics, and then it stopped there. As a cancer biologist and a cancer treater, the obvious thing to do is look at that area, and really very few people have moved into this field who either treat cancer or deal with cancer biology. And so though this is sort of a lateral move maybe for research so far, for us it's the obvious thing to do. So what can make breast cancer patients more likely to die of their breast cancer? And there's two things, and this brings me back to the title of my talk. We've got biology, so that's things about the innate nature of the cancer. And then we've got differences with therapy. How does treatment vary? And that included in therapy, I include traditional medicines. I also include diet and other lifestyle issues, which one could consider holistic therapy. I'm going to take you through a little bit of work we've done in some of these areas to see if we can explain why there is this increased death rate. So if I go back, so in the biology, I'm going to talk about the subtypes of breast cancer. There are some that are very low aggressiveness and they're not that likely to come back. There's some that are much more aggressive, much more likely to come back. Immune cells in a cancer can make a big difference. There's a very common concept that our immune system may kill off cancers before we know we've got them, and that's probably true. But when we've already got a cancer, the immune system can also do a lot to either control it or not. So we want to look at the immune cells in people's cancers. And also this pharmacogenomics, the biggest word I've got in my talk, and that's talking about the way our bodies deal with drugs. We all know that we may take a drug and somebody else may take the same drug. One of us is fine and the other one is violently unwell. And what is it that drives that? That's the way our bodies activate or get rid of drugs, which is pharmacogenomics. In the therapy space, I'll be talking about nutrition and particularly vitamin D and obesity, and then talking about chemotherapy and hormone therapies. So firstly, to biological differences, do Aboriginal women get different cancers? So this is the non-Aboriginal population, and we saw that the blue boxes are what we call luminal A cancers. These are very estrogen sensitive, low aggressiveness cancers. They're the ones you want if you've got to have a breast cancer. We've got the more aggressive estrogen sensitive ones in orange. In yellow, we've got the triple negative ones, well known to be more aggressive type. We see more triple negative breast cancers in Afro-Caribbean women, about double the rate of white women in America, for example. And then we've got the HER2 group, which is another aggressive type, for which we have quite a lot of treatments. So how did the Aboriginal women compare? And certainly we did see a difference. We saw 20% less people who got the really good blue, very estrogen sensitive cancers. We did not see a difference in triple negative breast cancer, though, exactly the same, 15%. However, we did see a doubling of the HER2 positive cancers and also in the doubling of those more aggressive estrogen driven cancers. And these differences have consequences for the way we treat people. Those more aggressive cancers need more and different treatments. What about immune cells? This is a cancer cell in green, and these are lymphocytes, our natural defense cells attacking that cancer cell. There are also other cells in cancers, though, that may be adverse, and they may cause the cancer to misbehave. And in fact, in estrogen-sensitive breast cancer, we know that certain types of lymphocytes can stop hormone treatments working. We didn't see, when we looked in Indigenous women, any difference in the triple-negative immune cells, but we want to look at the estrogen receptor-positive ones. Now, this is a quick primer on immune cells. I'm going to take you, these are two breast cancers, just to show you what we're measuring when we're talking about immune cells. And if I highlight the similar bits, in the boxes, these are the cancer cells themselves, and within the red rings, you can probably see those cells look very similar. If I blank out the cancer cells, though, you can see that what's left, the stroma as we call it, the non-cancer cell part, is very different. Here we have a lot of pink stranding material. This is just packing tissue, collagen and other things. Whereas here we have lots of blue dots, and that's the immune cells. So this is a very high immune cell cancer, very low one. And when we looked at the Indigenous patients, we saw that almost 50% of Indigenous women with estrogen receptor positive breast cancers had lots of immune cells versus less than 10% of non-Aboriginal women. And this would, research has shown this makes your anti-estrogen treatments, your most effective treatment in these cancers, much less effective. It does also mean we may be able to employ immunotherapy added to anti-estrogen treatment in Aboriginal women to make things work better. So it does give us a way in to maybe improve things. Finally, that pharmacogenomic term I mentioned, just to tell you what that's about. There was a couple of, we're just at the beginning of this work, but we think it's important. These are a couple of cancer drugs that we use. Capecitabine is used in, it's a tablet drug used for metastatic breast cancer, triple negative breast cancer, and also bowel cancer. And tamoxifen is a very well-known anti-estrogen. It's used in estrogen-sensitive cancers. Both of these drugs actually are not really drugs at all. They're what we call prodrugs. If you put these drugs in addition with cancer cells, the cancer cells don't care because these drugs are inert and they have to be activated by the body to a slightly different active form. And this is what pharmacogenomics are. Our bodies have protein machines that activate or don't these drugs depending on the exact nature of our genes. So there's a machine called DPD that activates capecitabine, and the active form of the drug is called fluorouracil. And some people have got very strong DPD that DPD gets rid of fluorouracil. So capecitabine has activated fluorouracil, DPD gets rid of it. So some people have very slow DPD and they get much bigger benefits from capecitabine, but they also get very bad side effects. And we wanted to know about Indigenous women. We in fact saw that unlike compared to non-Aboriginal women, we saw very few of these slow disposer genes. So it means that normal doses of capecitabine should be very safe in Aboriginal women, but we shouldn't underdose. We've also started looking at another machine called CYP2D6. It's only got a code word rather than a name. And this activates tamoxifen to endoxifen. And this is a work in progress. So we didn't get very good reads off the genes there. Not every experiment works every time, but we think this is important. And so we're going to go back and re-look at this gene, as this may explain why women with estrogen receptor positive cancers get less benefits from hormones. You all right? Yeah, go for it. You're lucky you missed pharmacogenomics, which is my hardest. No, that's quite all right. So moving to the therapy side of things in breast cancer, and we've just been talking about the Aboriginal women get different types of more aggressive breast cancers. So talking about the way we treat breast cancers, there are a number of different things. And the first thing I'm going to start about is that more holistic concept of nutrition and general weight and body habitus, as we call it. So firstly, vitamin D levels. It's been shown that low vitamin D at diagnosis makes you more likely to die of your breast cancer. In fact, women with low vitamin D compared to replete vitamin D were 10% more likely to die of their breast cancers. So what about Aboriginal women? Well, we found that in fact the deficiency in vitamin D was twice as frequent, almost 50% of Aboriginal women compared to 25% of non-Aboriginal women. And so this could certainly add a small percentage to that extra death rate. When we looked at body weight and obesity, this does not show that not everything is different. We did not see a difference. We saw that there was no increase in being overweight or obese in Aboriginal women compared to non-Aboriginal women. We did, however, see that over 3/4 of our breast cancer patients were either overweight or obese. So it is an issue we need to help them to try and address, as being overweight or obese does make, again, estrogen-targeted drugs not work as well as fatty tissue makes estrogen. And there are other things that fatty tissue makes that can make cancer misbehave. And then finally, what about cancer drugs beyond the holistic lifestyle things? So lots of people looked at surgery and radiotherapy and not seeing big differences, but there are a number of other steps to get as close to the cure door, if you will, as you can in breast cancer. And those steps in breast cancer tend to be chemotherapy, hormone therapy, and targeted treatments. And Herceptin is a HER2 targeted drug that's particularly effective. So firstly, with anti-estrogens, what did we see in Aboriginal and non-Aboriginal women? Well, we saw that Aboriginal women are slightly more likely to decline anti-estrogens, and this may be personal choice, and we obviously everybody as 100% right to choose their own health options. It may be, however, that we're not explaining it as well, the benefits of these drugs, which often have got low side effects, not always, but often, and good benefits. We also saw in younger women, we tend to give half of one type of anti-estrogen and half of another. And probably about 40% of the women in these populations are in that category. And of that 40%, we saw a bit over half got the perfect combination strategy of anti-estrogens in non-Aboriginal people, whereas it's only about a quarter of those Aboriginal people, women got that perfect combination. And that may be, that switch is made a couple of years after breast cancer has initially been treated. And so maybe better follow-up and better input down the track would help with that. We also interestingly saw a lot more side effects for the same drugs in Aboriginal women. With anti-estrogens, we saw, looking at grade 3, which are really nasty side effects, we saw 34 compared to 17%, so exact doubling. And this may go back to that pharmacogenomics I was talking about. Aboriginal women may activate the drugs better, so they may be getting better benefits in theory, but then what we did see then was that there was Aboriginal women were 3 times less likely to finish treatment. Finishing 5 years of standard hormone treatment, it was 90% in the non-Aboriginal group and 70% in the Aboriginal group. And finally, what about chemotherapy? Nobody wants to have chemotherapy, but we certainly we try and explain it as well as we can, and most people do. If we've recommended it for chemotherapy, we don't recommend it in everybody. So what about chemotherapy in Aboriginal women? Well, we did again see still we're looking at, we saw 19 versus 8% refusal. Still, it means 81% of people accept chemotherapy compared to 92%, but again, it chips away at that survival curve. We also saw on the doctor side of things that doctors appeared to give less intensive chemotherapy to Aboriginal patients. Looking at optimum strength of chemotherapy, it was about 75% was optimal strength in the non-Aboriginal population compared to 45% in the Aboriginal population. Now, you might think it should be 100%, but sometimes we dial down the dose if people are less fit or we're concerned about particular side effects. So we never expect it to be 100%, but certainly it's a lot further from it in Aboriginal people. When we looked at advanced cancer, once your cancer spread outside the breast and lymph nodes, gone to other places, we then looked at how many therapies. What we tend to give there is one therapy, control the cancer as long as possible, and then switch to another one and another one and another one. And how long you live tends to be a mosaic of how long your cancer is controlled by each one. We saw that Aboriginal women got a lot less lines of treatment, as we call it. We saw getting to 3 lines of treatment, it was somewhere between 3 and 4 out of 10 people who are non-Aboriginal, compared to only 1 or 2 Aboriginal people, less than half. And the average number of treatments people got with advanced breast cancer then went from 2.5 down to below 2. So this is the biggest part of the talk, you'll be glad to hear. This is breast cancer. We've been working on it for the longest. I know a bit more about it than some of the other cancers. Where have we got to with this? We had that 18% of people were dying and we didn't know why. So how has this helped us chip away at that? Pretty good, really. It's a bit of a back of the envelope calculation, but what we estimate is that we explain about 2/3 of that detriment with vitamin D deficiency, aggressive types, immune infiltrates, differences in pharmacogenomics, differences in adjuvant hormones not being completed, less intensive chemotherapy, and less advanced cancer treatment. Okay. So that was our pilot. We'd found a lot of differences that many people thought we wouldn't found some things we can do stuff about, which I'll come to at the end. And so we then, buoyed on by having found some useful things in breast cancer, we also then moved into a second and a third cancer. And the next area we looked at was head and neck cancer. And as you may remember, head and neck cancer, the biggest survival gap for Aboriginal people in Australia was 26%, extra deaths. And we saw, this is our population at South Metro compared to non-Aboriginal people, and we saw about that 30%, in fact, a little bit higher again, same as breast cancer, 30% extra people dying of their head and neck cancers. Now, each cancer is different in what may drive it, what may cause it, and how it's treated. So we can't just do what we did in breast cancer and go, oh, we'll just keep doing the same thing. We have to think about the nature of the cancer, what drives it, and how we treat it. With head and neck cancer, there are some factors that we've been able to look at that we know to be important. There are some cancer factors, again, something about the nature of the cancer itself. Head and neck cancer, a start, you might say, what is head and neck cancer? It's a bit of a big area, and head and neck cancer is a collection of different cancers, the tongue, the voice box, the larynx, also the lining of the mouth as well, and so on, and also the sinuses. So there are different types of cancers. So we want to look at, well, maybe Aboriginal people get different types of cancer within the head and neck classification. What about the stage of disease again? Are they more advanced when they present to hospital? And then also about the cause of cancer. There are different causes of head and neck cancer that can cause more or less aggressive types. And also we wanted to again look at therapy. And here are the delays in diagnosis. Breast cancer, we hadn't seen delays in diagnosis, other people hadn't either. Not really known in head and neck cancer. Or was also treatment often accepted different, and also what were barriers to care. There aren't quite so many markers in head and neck cancer that define treatment like breast cancer, but there are certainly, it's an intensive type of treatment, and there may be many things that stop people going for the optimum treatment. So firstly, cancer factors in head and neck cancer. Firstly, are different sites affected? And this is and what fits into the constellation of head and neck cancer. And we're seeing nasal cavity, tongue, larynx, the throat, and so on. And in fact, we did not see a difference. We saw that Aboriginal people got exactly the same spectrum. The blue bars are Aboriginal people, orange are non-Aboriginal people, and there was essentially no difference. So certainly it's not, and some of these cancers do better than others. The larynx is actually quite a good one to get. The tongue is not such a good one, and so there wasn't a difference. So what about stage? And again, here we did see a difference. We saw nearest to me here, these are early cancers, stage 1, 2, and 3. That means that they're still within the head and neck area, they're not spread elsewhere. And we saw that stage 1 cancer is much more common in non-Aboriginal people, 3 times as many, compared to the stage advanced cancers, which is the stages 4, A, B, and C, which are more common in the Aboriginal people. And if we summarize that, we see 3 times as many non-Aboriginal people got stage 1 cancer, the easiest to cure. And that difference transplanted to the worst kind of cancers, the stage 4 ones, where Aboriginal people were 20% more likely to get those later cancers. The third thing we looked at is whether the cause of the cancer varies. There are 2 basic causes we know about of head and neck cancer. The one we know about for longest is tobacco. And the second one is the papillomavirus. This is also, some of these viruses also involved in cervical cancer, and vaccinations against these viruses really drop the cervical cancer rate. So papillomavirus and targetix really got some promise in head and neck cancer. As if you get papillomavirus in the throat, you're more likely to get head and neck cancer. But one thing we do know is that tobacco-caused cancers tend to do worse than papilloma-caused cancers, which are in non-smokers. And what did we see? Well, we saw that the viral-caused cancers, again, were more common in the non-Aboriginal people. About a 20% more non-Aboriginal people had a viral cause. And conversely, we saw that those extra cancers were caused by smoking in the Aboriginal population. This means that maybe vaccination strategies may be a focus over here in the non-Aboriginal population. Smoking cessation, nicotine replacement therapies and things of this nature, and education may be important in the Aboriginal population. And particularly in the heavy 1 to 2 packs a year, we saw 20% more Aboriginal people. So that's the cancer factors. We see the sites are the same, the stage is later, and we see the cause is different. What about therapy factors? Delays in diagnosis we looked at, the treatment offered and accepted, and barriers to care. And just before I carry on, just to tell you about how we treat head and neck cancer, people often have big operations. These operations take 6 to 8 hours and involve reconstruction of the head and neck. We have radical radiotherapy, which is the highest dose of radiotherapy get where there's severe inflammation. People often have to have feeding tubes, either through the nose or into the stomach, because the radiation causes swelling and you can't eat during that period of time. We also add in chemotherapy to make these things work better. It's very intensive treatment. You're really, can be away from home because that radiotherapy is only available in big centres. You're really away from home if you're in regional remote for best part up to 2 months. So that's the context of when we're talking about treatment. So as we looked at delays, was there a delay in Aboriginal people seeking help from their doctor when they got symptoms? The popular concept is that there's more of a preference to going for alternative or natural bush medicines. We did not see that. We did not see a delay in Aboriginal people seeking help with symptoms. What about when the person goes to the doctor? Does the doctor drag their heels? And was there a delay in diagnosis when somebody's picked up at their doctors? Again, we did not see that. We saw that slightly more Aboriginal people were diagnosed between 4 and 6 weeks rather than between 0 and 4 weeks, but it was only about a 10% difference, and it was only a couple of weeks difference. So essentially, we did not see a significant difference. Where we did see a difference, though, is the how many people got curative treatment, particularly who could have had a potentially curative cancer. So we looked at people who had those earlier stage cancers who potentially could be cured by this radical surgery, radiotherapy, and chemotherapies, and we looked at differences there. The way we deal with cancer is we have a multidisciplinary team meeting. So the group of specialists, not just doctors, specialist nurses, dietitians, physiotherapists, geneticists, all get together and discuss each person's case. It's been shown if your case is discussed in an MDT, your survival is better if you're a cancer patient, regardless of whatever else happens. So in the MDT, everybody's case got discussed in MDT in both groups, so that was good. We saw that about similar numbers of patients were recommended for curative treatment who had an early stage disease, 90 compared to 84, a small difference. When we looked at what was recommended by the doctor, though, we saw a 10% gap open up, extra gap. Everybody who was recommended by the MDT for curative treatment was offered it by their doctor, but not in the Aboriginal population. And then we saw when people were offered curative treatment, another 10% gap appeared with Aboriginal people declining curative treatment, whereas there was very little declining in the non-Aboriginal population. This may talk to bias, may talk to unconscious or conscious bias in doctors, may also talk to poor information, or maybe non-holistic and non-culturally appropriate services to give people that what they really need for support across that very tough treatment. We did look at the barriers to curative therapy here, but at common reasons for the doctor offering different treatment to the MDT. The doctor felt the patient was unfit for treatment. The MDT, the patient isn't there, so they don't see how the patient is, and they're not able to look at how other health problems may affect the patient. So that was one of the issues. The patient actually was declining treatment that the doctor was recommending was another cause. And then there was, sadly, some people, their cancer got worse between having their first scan and coming to agree to have curative treatment. Common reasons for patients opting out of curative treatment: concerns over the side effects of chemo and radiotherapy, and they are not light treatments, not wanting to have extensive surgery, not wanting to have tracheostomies, which is a breathing tube, which you sometimes need, or a feeding tube, and also wanting to be able to return home or to be treated with the support of family. And I'll come to how we might address these things at the end when I summarize, but certainly lessons for us in designing services. Finally, in short, is lung cancer. And this is a cancer we came to just last year. And to remind you, lung cancer is the most common diagnosis in Aboriginal people, and the death rate in Aboriginal and non-Aboriginal people is very high. So anything we can do to improve lung cancer treatment is a good thing. Firstly, lung cancer, this is like circa 1920. If you've been a doctor in 1920, lung cancer was just lung cancer. It was lumps in the lung. About 1924, we did learn, and this is all that was known when I was a junior trainee, not quite 1924, but a bit after that. We'd worked out that lung cancer came in small cell and non-small cell variants, and the non-small cell would divide into a glandular and a lining of the lung type of thing. So we had small cell, we had squamous cancer, and we had adenocarcinoma. And they're different already. We give chemo only to small cell ones. They're very hard to cure by local treatment, whereas surgery and radiotherapy for early non-small cell ones we hope to give. And this is relevant because they've got different survival, so we had to divide the Indigenous population into those two small cell and non-small cell groups. Now, one thing I would say about lung cancer, we're still working in this space. We just started this last year. So we have looked at the Aboriginal population. We're still working on the non-Aboriginal matched population. So what I'm going to show you is comparisons to general Australian lung cancer patients. But in small cell lung cancer, it's divided into local to the lung or gone elsewhere, and small cell lung cancer travels elsewhere very quickly. We saw similar results to what we see in non-Aboriginal people. Limited disease in one lung, it was 25% cure. It's about probably 30 to 35% cure in general population, so only a little bit lower. An extensive disease, which is the orange bar, we don't tend to cure that, and that's what we saw. We saw a 0% cure rate. When we looked at non-small cell lung cancer, there's a bit more difference there. It's not just chemotherapy as the standard treatment. There's lots more complex treatment. Here, these are stages. Blue is stage 1, orange 2, green 3, and red 4. You may be getting used to these curves that oncologists get so excited about. Now the survival curves we see, the line is dropping as the stage gets bigger, as the cancer becomes more advanced. One thing we did notice here is the stage 1 cancers. These are the smallest, most curable cancers. They didn't seem to do very well in Aboriginal people. And these are the same figures again. This is the Aboriginal population here, the stage 1, 2, and 3, and 4. And this is general Australian patients from across Australia. And we see that the cure rate we might expect is about 2/3 from the general population, and we saw about a 20% drop in stage 1 cure rates. whereas we didn't see a difference in cure rates really for later stage cancer, and that's probably where we need to focus our efforts. What about smoking? Again, lung cancer. Everybody knows smoking is a big cause, but there are other causes, pollution and certain industrial factors. And smoking status, unfortunately, in the Aboriginal lung cancer population was almost ubiquitous. 97% of people were either relatively recent ex or current smokers. We only had 6 patients out of 209 that were non-smokers. We expect in an Australian population about 80% of lung cancer patients to be smokers. We didn't see, however, a difference in survival if you were an ex or a current smoker, which is something that has been observed elsewhere, just something we're looking at for interest. Suggests we always encourage people to give up smoking in any case because of many other health benefits for that. We didn't see an impact on lung cancer. Finally, in lung cancer, the final thing I'll talk about is we've looked at the treatment and whether people are getting the best treatments. Surgery and radiotherapy and chemotherapy in lung cancer in Aboriginal people has been studied. Surgery and radiotherapy has been found to be given at similar rates with slightly higher refusals of treatment, but only very slightly. But the most recent advents in lung cancer treatment, 2 other types of treatment. There are now targeted treatments, particular things that have gone wrong in lung cells to make them lung cancer cells, and also immunotherapy. So this is what I had to know when I was a trainee about lung cancer. If I'd been in 1920, I would have just had to know it's lung cancer. What do my trainees have to know? Well, they're less lucky. We now know that lung cancer can be divided into all of these different subtypes, each of which is driven by a particular gene that's gone wrong in those cancers. Now, we can't do much about most of these things. A lot of these things is a little bit of research interest, but there are 2 now we can treat very well. These are 2 things we can detect in lung cancer that have gone wrong. One's the epidermal growth factor gene, receptor gene. If that goes wrong, this is a gene that's involved in controlling growth in cells. When it gets mutated or damaged in cancer, it gets jammed on and the cells can't switch it off. And those cells keep dividing and dividing and spreading, and that's what a cancer is. And similarly, the ALK gene is another one that does a very similar job. And we've got now very good jobs. When there's a very small defect in the gene and we're able to target these proteins that are abnormal and switch them off, being as the cell can't do that normally. So we're looking for the Achilles heel, if you will, of these cancers to try and treat them better. In EGFR and ALK, we have treatments that can block both of these. And this is what we see when we give an EGFR blocking tablet. This is one of those tablets. This is, here we've got chemotherapy and how long it controls your cancer compared to EGFR blocker. In fact, these tablets control lung cancers where you've got that gene gone wrong for 3 times as long. In fact, we've got patients with 4 or 5 years with advanced lung cancer still on these tablets. And a similar story with the ALK mutations, again, about 2.5 times as long by blocking that gene. And these tablets are now available in Australia, funded by the public system. So we want to be testing all lung cancer for all these. We want to find them because these people do really well if we get them the right treatments. So what about our Aboriginal lung cancer patients from WA? Well, we saw somewhat lower rates of mutations than we might have expected, in fact. We saw that ALK was about 3% and EGFR was about 9% of the population we tested. And just to compare that, this is an Australian population from Peter Mack. He was EGFR is 27%, ALK's 8%. And again, I'll put up the WA Indigenous figures. We're seeing about 3 times less mutations in Aboriginal people. Why is this? Well, it's probably because these mutations are most common in non-smokers. And so because all of the Aboriginal people almost were smokers, then they're less likely to get these genes. They're much more likely if you're smoker to get all kinds of genes going wrong in minor ways, much less targetable. So it looks like even though we want to test all Aboriginal people, it's less of a focus in Aboriginal people looking at targeted mutations. What about the other thing I talked about, immunotherapy? And that's, again, this cancer cell being attacked by lymphocytes. And you probably have heard of immunotherapy, and immunotherapy is becoming increasingly common in cancer treatment, has become very successful in terms of treatment. Melanoma is the poster child of immunotherapy. For advanced melanoma at 5 years, we used to have about 3% of people alive. And now at that same time, we've got about 65% of people alive from melanoma. It's transformed that disease. And it's not done as much for lung cancer, but it's certainly made a difference. What do we look at in the cancers? Well, we look for a signal that immunotherapy will work. Some cancers have a kind of an invisibility cloak. They make a chemical on the outside that tells the lymphocytes, those cell-killing immune cells, that I'm a self cell, I'm friendly, leave me alone. This is the programmed death 1 protein. And so we look for programmed F1 proteins on immune cells and on cancer cells. And if they're there, it means immunotherapy may work really well to remove that cloak of invisibility and have our immune system attack the cancer. If that cloak is not there, if there is no programmed F1 system in those cancers, it means that there are other reasons the immune system is not working, giving immunotherapy is unlikely to work. So here we've got a PD-1 programmed F1 negative lung cancer, and here's a positive one. So we're looking for this difference. There's a low benefit from immunotherapy here, a high benefit there. What about Indigenous or Aboriginal people? This, before I go there, this shows what the benefits of immunotherapy are in lung cancer. When we look at 5-year survivals compared to chemo, which is our older treatment, it's up from 5% to 30% for advanced lung cancer. And in fact, about half of those people are still alive and cancer-free at 5 years and are probably cured. It's not 100% by any means, but it's certainly a lot better than the 0 we see with chemo. So what about the Aboriginal population? To distill down this fairly complex set of figures, the PD-1 positive, which is more than 50% of the cells with that marker on, is about just a bit over 50% of Aboriginal lung cancers. And this is data internationally from about 7,000 patients around the world. And we see that that's almost double what we see internationally. So certainly Aboriginal people have a signal that they might benefit significantly more from immunotherapy. So to briefly summarize in a couple of slides about what we plan to do about this. Firstly, breast cancer, we saw higher grade and more aggressive types of breast cancer. We also saw higher stage. We saw more adverse immune cells in the cancers. We saw more vitamin D deficiency, easily correctable. We saw less intensive early chemotherapy prescribed and more hormonal side effects leading to less people finishing their hormone treatments. We also saw less therapy in late cancers. Head and neck cancer, we saw the same sites were affected, not a difference there, but there were more smoking and less viral causations. We saw also higher stage. But we also saw, though delay was not an issue in terms of diagnosis and treatment, less people were being offered or accepting curative therapy, and we may be able to improve our services to increase that acceptance rate. And issues there we identify were concerns over side effects and time away from home. And finally, in lung cancer, we saw the basic types had similar frequency. We saw a survival was poor in stage 1 cancer. We need to look at surgery, radiotherapy, and other treatments there. And that's a work in progress. We saw later stages were more similar. It was just worse in the stage 1 cancers. We saw smoking was more prevalent, close to 100%. Targeted mutations are rarer, but immunogenicity and potential benefits from immunotherapy are higher. And so finally, the last couple of slides, what can we do about this? We found lots of things. We can publish some papers, but that's not really going to help anybody in terms of those very poor survival rates. The first thing is to identify people. We've studied people years after they got their cancer. We need to know when people are being diagnosed and identifying them. And the way we thought about the cancer registry, but that's too slow. It takes a few months for people to really come through the cancer registry and be recognized. How the cancer registry get their data, though, if you get a biopsy or an operation that's got cancer in it, then that information, that pathology report, the study of your cancer under the microscope, goes to the cancer registry. So we're working with the pathology departments who know within a week or so their list of people who have been diagnosed, who've identified as Aboriginal. So we're working with the pathology departments to get identification of people who've identified as Aboriginal who have cancer. Once we know who's been diagnosed as they're being diagnosed, we can then potentially help. Every person with cancer, as I've mentioned, has their case or should have their case discussed by a multidisciplinary team meeting. And we're setting up a second type of multidisciplinary team meeting, an Aboriginal specific one. So the idea is that the cancer person's cancer will be discussed in the cancer specific one, or the lung cancer experts, or the breast cancer experts, head and neck cancer experts in different meetings. Then the Indigenous people with cancer, their case would also be discussed again to Indigenous MDT. And there we would apply all the things we've learned about these different cancers, what kind of treatments that may help, different barriers to hopefully improve the plan. So in terms of, this is sort of a little bit the centerpiece of the strategy. And so what might a multidisciplinary team meeting that's specific to Aboriginal people bring? Well, the best individual plan from what we've learned already. Culturally focused information. So we can create, and there are information materials for people who are in Aboriginal who have cancer. It's very hard to get them to every person because everybody's diagnosed in such a a spread out and fragmented way. How do we get those materials to everybody? Well, if we know who's being diagnosed, as they're diagnosed, we can do that. We can refer to regional remote treatment services, which I'll come to in a minute, as we've been designing those. We can provide care plans and survivorship guides, giving instructions to the people and their carers what behaviours and what things they need to worry about, not worry about, to look after themselves with their cancer. We can look after other diseases people may have alongside, heart disease or lung disease, commonly in lung cancer, for example. And we'll bring specialists in to help them optimise the care of those other conditions so they can have the best cancer treatment. And also we're looking at integrating knowledge of bush and traditional medicine that Auntie Robin mentioned, both from the point of view of holistic approach to care and also looking at the interactions. If people are on bush or traditional medicines, they may interact with standard conventional medicines, and so we want to know about what people are on, and we can provide advice for combinations that may work or not. That's the general approach for each patient. Then we've got some specific things we can bring into the plan. For breast cancer, we can check subtype and make sure the treatment's best for the subtype. We can make sure the optimum chemotherapy is given. We can check vitamin D levels and recommend supplementation, and we can deal with hormone side effects to keep people on their hormones. For head and neck cancer, we can get better information so people are well informed in terms of accepting or declining treatment. We hope to be able to develop more appropriate accommodation and supportive services with that very long intensive treatment period, and also smoking cessation, as that is such a big driver. And in lung cancer, again, mutation testing and therapy, although that's a smaller proportion of Aboriginal people, but certainly optimising the immunotherapy benefit we expect to be there, and also smoking cessation around there. Once we've done looked at coming through that MDT, as we know, Aboriginal people tend to be more regional and remotely located. This is, in fact, every person with lung cancer who's Indigenous diagnosed in our group. And thank you to Lisa Spalding, who's in the middle of the audience, is my research associate, who's helped me with a lot of this work and has also found a very quick way to map people. But we see that there's a very big spread. If you need immunotherapy, if you need chemotherapy, where can you go? Well, as we know, that it's actually pretty south-ocentric, and there are many people that are thousands of kilometres away from treatment. And how we've approached this is we've now built 3 video chemotherapy centres in Karratha, in Broome and in Narrogin, which can be used to treat Aboriginal or non-Aboriginal people. So you now got a lot close to home treatment. We're looking at expanding those. What do these involve? Well, they involve locally in Perth at Fiona Stanley, we have an oncologist and a pharmacist, and then on site we have a local doctor, we have an Aboriginal healthcare worker, and we have a chemo nurse who can deliver the treatment. We assess the patient by video link, the local doctor can examine things if need be, and the nurse can deliver the chemotherapy. So we have our regional video chemotherapy clinics, and then finally we're looking at dealing with side effects, not managing to stay on your anti-estrogens, things like tablets for lung cancer. We're thinking that follow-up and helping people manage side effects of tablets, to optimize their lifestyle, look at vitamin D again, diet and exercise, may also be a big help here. And we're looking at a network of people who do home and telehealth follow-up clinics, specialist people to look after people's treatments. One of the feedbacks we've got from our Indigenous representatives are a lot of people are at home and they're getting side effects, and the GP is the only person who's contacted who's got very few people on that treatment. So if there's a system everybody's aware of that they can routinely use for help, that should help too. And finally, we're going to collect all the information and make sure we're improving things. Important to do it, but also keep an eye on the fact that it's working and tweak it if we need to. And so finally, very summary slide here. Breast cancer incidence is lower in Aboriginal women, probably due to lower genetic risks and possibly lower breast density also. Mortality, the death rate is higher though, driven by higher stages, more aggressive types, more harmful immune cells in the cancers, and more vitamin D deficiency potentially. We also, on the treatment side, see less intensive chemotherapy delivered, more hormone side effects, and less treatment for advanced cancers, which adds to the problem of the more aggressive biology. Head and neck cancer mortality is also higher. We see more smoking-related cancers that tend to do worse. We also see more people declining curative treatment that we need to work on also. Lung cancer mortality, again, higher, particularly for early cancers, and we're looking in detail at the early cancer treatments. More smoking-related cancers, which tends to lead to less potential for those targeted treatments, but more benefit from immunotherapy potentially. We need to bear that in mind, that balance in trying to get everybody the best treatment. And then finally, we are designing and rolling out a statewide approach to patient recognition, optimal planning, and culturally appropriate and locally delivered services. And finally, but not least, acknowledgement to all the people that have been involved in this research. And there are a few extras. This keeps expanding. We have people who are involved in cancer biology, including Lisa, who's run a lot of this, and also is my ethics guru and looks after ethics and governance, which is one of the slow parts to getting research started. We have statistical help, cancer genetics, administration and coordination. We also have cultural and social studies. This is Leanne Pilkington, a Noongar lady we've been working together for about 15 years. She tells me I'm now more, but I don't know. I haven't got a certificate for that yet, but she's been working with me and guiding this work and brought in other people of relevance with Indigenous heritage to help, including scientists. We also have cancer services people. Wayson Lamb is the head of Fiona Stanley in Hospital Medical Oncology, also been a big driver in rural and remote services. Stromal density, mammographic density, Jen Stone is one of the international gurus of density, and the treatment teams as well, who've been looking at these treatment patterns for Aboriginal people. Thank you for your attention.